Okay, I think we're about a minute or two over, so I think we should start the meeting. So welcome all members and guests to Thurrock's Health and Wellbeing Board. It's the second meeting of this municipal year. We do have some technical issues today. I understand that our screen in terms of putting on presentations, that facility is not available, but the presentations will be put on the website after the meeting. I'd also just like to welcome Rob as the new Interim Director for Adult Health as a new member to the board. Are there any other new members to the board? Hi.
Afternoon. So I'm Scott Edgerton. I'm the new Chief Superintendent for Policing in the West of Essex, obviously covering the Thurrock area as well as Harlow and Brentwood. So my first of these meetings, first time in the council chambers as well. So nice to meet you all.
Well, welcome. Okay. Right, so this is an in-person only meeting. And this is a committee of the council, and the meeting is being recorded and streamed live on the council website. We will continue to use a flag system for those of you who have not been used to it before. So a flag will go up 2 minutes before the end of any presentation or any of the question times. Right, we'll ask you to stay in your allocated seats because the camera will go to you when you speak, and if you move seats, the wrong name will crop up. So I'm not aiming to be Susan. Right, can I just remind members that to turn off their mics on and off after when they speak, okay? There's no fire alarms planned, so if the alarms go off, it's probably the real thing and you'll be escorted out by the council staff. Right. Do I have any apologies for today's meeting? I do have apologies from Councillor Kent and Jim Nicholson. Are there any other apologies?
Just from Claire Demmel, Councillor Hooper.
Thank you. Right, so we'll move on to item 2, the minutes of September's board meeting, which is on page 5. I think...
Sorry, Councillor Hooper. I'm representing Jill Burns from NELFT and Alex Green from EPUT as well.
Thank you, Rita. Okay, so can I just move on to the minutes of September's board meeting, which are provided on page 5 of today's papers. There was a discussion around members agreeing the consequential amendments to the terms of reference, and members approved the Better Care Fund update template for 2024-25 and the year-end reports 23-24 and the first quarter report of 24-25. Are members happy to agree the minutes of September's meeting? Agreed? Okay. Just to introduce Gloria, who's just come to the meeting. She's a new member of our team within the housing team. I can't remember your precise title. I do apologise, Gloria.
Thank you very much. And yes, I'm the Chief Officer and responsible for housing, economic development and skills and regeneration. Thank you.
Thank you. I've received item 3, no urgent items of business. I've not received anything. Right, this meeting was trialled a 4 till 6 to try and enable as many councillors to come. But I'm kind of disappointed that we've not got more people here, and I think it's probably because we're not holding the meeting during the day. So I think we've decided that January's meeting, which is a date still to be agreed, will be held during the day to see if we can actually get more people to come. Right, item 4. Is there any declarations of interest in today's meeting? I take that as a no. Right, so I'll move on to item 5, the work and health report. There's 20 minutes for this item. It's on page 11 of today's papers. 20 minutes has been provided on this, as I said, on this item. 10 minutes for the item to be presented, and 10 minutes of questions. And I'll ask Sharon if she'd be kind enough to present, please.
Thank you, Chair. So the report in front of you is quite a short report, which is asking the board to consider establishing a subgroup of the Health and Wellbeing Board with a focus on coordinating work, the work on employment and health, or work and health. So I'll just pull out, I'm assuming that colleagues have read the report, so I'm just going to pull out just a couple of points. So we know that almost 1 in 5 people of working age in the UK report a long-term health condition that affects their ability to work. And across the UK, we're talking about around 8 million people. And what the data also shows us is that the number of people that are economically inactive because of a long-term health condition is actually increasing. We know that the COVID pandemic has had some impact on that, but there was some evidence to indicate that actually that number was going up before the pandemic. So the increase isn't wholly due to the COVID-19 pandemic. And more recently, we also know that the cost of living crisis is having an impact on people both in work and outside of the employed workforce, and we know that that is worsening existing inequalities. You cannot have good economic growth without good health. So you cannot separate employment and health. There is a symbiotic relationship between them both. So when we look at Thurrock, we know that Thurrock has high levels of people of working age who are not in the workforce because of ill health. The Health and Wellbeing Strategy has already identified that as a priority, and those of you who have had an opportunity to look back on our current Health and Wellbeing Strategy will have seen that work and health is already listed as a priority there. And it is true that there is some progress being made across Thurrock on this agenda. But we have not got the work progressing at pace or at the scale that it needs to be at to see the improvements that we need. It's quite a stark figure, really, that 30% of the people who we know are economically inactive in Thurrock are on long-term sick. So that's 30%. Of people who are not economically active. That's a significant proportion of our working age population. And clearly, we need to do something about that. The evidence suggests that work is generally good for people. So research evidence suggests that there are a number of benefits of being in work for people with long-term conditions. So good quality employment can aid recovery and rehabilitation. It leads to better health outcomes. It minimises the harmful impacts that a long-term health condition can create for people. It enables better participation in society and can also help to reduce poverty. Whereas we know that unemployment for people has the opposite effect. And we know that unemployment, forced unemployment, is associated with an increased risk of lower life expectancy and a range of health conditions, including cardiovascular disease, mental health issues, suicide, and can also lead to health-damaging behaviours as coping mechanisms such as smoking and alcohol misuse. And we know that the long-term unemployed, so people that have been unemployed or have been out of work for longer than 6 months, are particularly at risk. But this isn't about encouraging people into work for work's sake. Work can be harmful to health as well as positive. So what I'm proposing the Health and Wellbeing Board needs to be seeking as part of the recommendation here is that we also work with employers to ensure that they have got opportunities to be able to support their workforce to be in good health. A recent report published by the Health Foundation then suggests a number of key things that need to be in place to help places like Thurrock take this agenda forward. So that means proactive initiatives in the workforce to support worker health, such as health checks, for example, stop smoking support, early and effective support to keep people attached to the labour market. So part of this is about working with perhaps our small and medium-sized employers who don't have access to occupational health departments to be able to work alongside them to help maintain the health of their workforce. We work early on with partners such as Job Centre Plus and GPs writing fit notes so that we're actually identifying people as early as possible and signposting them into appropriate sources of support, and then improved health support to help people back into work. Since I wrote this report, Chair, there's also been some additional information released by government. So government have written to integrated care boards, other NHS colleagues and local authorities about a supported employment programme. So the government, Department for Work and Pensions, but across government department initiative, will be introducing a supported employment programme, which is really aimed at tackling economic inactivity and hidden unemployment through a new locally delivered supported employment programme. We know that Thurrock will be part of a Greater Essex programme that will be led by Essex County Council as the lead agency, but it will be partnership working across Southend, Essex and Thurrock. There will be, I understand, additional funding that will be coming down to local areas to support this agenda. So I would propose, Chair, that this report is very timely and that by establishing a programme board focused on work and health, it will allow Thurrock to bring the different strands of work together. It will allow us to have a very clear and strong voice for Thurrock in a Greater Essex partnership. So in summary, then, Chair, the recommendations in the report are for the board to, first of all, approve the development of a work and health programme for Thurrock. The paper suggests that that's led by the Director of Public Health, but there's since been some internal discussion within the council, and a proposal that the work programme is led jointly by myself as DPH and Gloria in her Chief Officer role. And then the second recommendation is for the board to agree to the establishment of a work and health programme board as a subgroup of the Health and Wellbeing Board to oversee the delivery of the programme. So I commend the report to board members. Thank you.
Thank you, Sharon. Does anyone want to comment or say anything? Margaret.
Thank you. Really good timing, Sharon. Absolute perfect timing. And I'm presuming that the programme board, if it's approved today for Thurrock, will be linking in with the work that we're starting to develop within the ICB. Thank you.
Sorry, I nodded. That wouldn't be picked up by the microphone. Yes, thank you. In response to Margaret's query, for colleagues who may not be aware, the Mid and South Essex Integrated Care Board and the Integrated Care Partnership has identified work and health as one of their priority areas. The three directors of public health across Southend, Essex and myself for Thurrock have been involved in those early conversations, and yes, our Thurrock focus, I think, will allow us to be able to contribute to that work really well.
Okay, I think it's a really good timing too, because I think Thurrock has great opportunities, particularly in the next 8 years, with the investment and hopefully lots of new businesses coming to the area. And I think the opportunity for people to find work and improve the quality of their lives through better health and better housing, because we know if people have more money, they have better health and better housing, is nothing but good. But it's just actually getting a programme together that actually helps people back into that workplace when they've been off for so long. So I really approve of this. So unless anyone else has got anything to say, shall we just go to the recommendation, which I think you've already read, but shall I just go through it again? Rob?
Sorry, can I just ask one thing on it? Obviously, I'm very new, and Sharon, I haven't had a chance to discuss this. Again, I think the paper's excellent. Support the recommendation completely. I just wonder, would it be appropriate within this subgroup, or is it to be dealt with separately? One of the things I'm wanting to explore is the opportunity for people with a disability in the borough to actually access meaningful work. And I'm just wondering whether it'd be possible to whether it would come within the terms of reference of this subgroup to look at opportunities for people with either a learning disability, physical disability, sensory impairment, or mental health condition to look at meaningful work opportunities.
I think yes. What I would like to see this subgroup of the board do is really to get a grip of the work and health agenda, to look not just at the people with long-term health conditions, which I know is the government's focus around the supporting employment programme, but this is really about trying to create opportunities for everyone to be able to engage in work. So I would very much include the particular groups in the community that you've mentioned, Rob. I suppose thinking particularly of our voluntary sector colleagues, not all work has to be paid work. And not everyone is ready to go into the paid workforce. So there is also a really valuable role for volunteering and thinking about how we can support people to become really active and engaged in their communities and be supported with skills, but also with whatever issue they may be experiencing. So we know that the three main reasons for people to be on a fit note, so we can access GP data, we can look at the reasons why people are being put onto a fit note. So for Thurrock, musculoskeletal issues such as back pain, other problems, anxiety, depression, and respiratory concerns are the three primary reasons for people to be economically inactive, as well as a range of other long-term health conditions that, through working in partnership with the NHS, with local businesses, the council, other anchor organisations, community and voluntary sector, and with people themselves, I think we have a real opportunity in Thurrock to be able to make a positive difference. So perhaps a lengthier answer than you were expecting, Rob, to that question, but in short, yes.
Margaret?
Thank you. It's a bit broader than that, actually, Sharon, in terms of opportunities, because, you know, we also have drug and alcohol services and such like that are also working towards getting people back into work. And that's also tied up very much with the general health and well-being of any individual. And I think it feels now as though it's all just starting to come together and to coalesce into a much more coherent approach. Thank you.
Mark?
Yeah, I was going to say a similar thing, really. I think that there is lots of voluntary sector organisations that are already doing work in this area. I think probably the issue is the kind of the scale of which they're operating. I think it's predominantly quite small charities working kind of very locally. So the kind of size of the impact is going to be, is going to be reflected in that. And I think they're probably working quite isolated. So how we kind of pull this together into kind of proper pathways, I think, is the challenge. But I absolutely welcome this initiative. I think this is exactly what we need to be doing at this time.
Gloria?
Thank you very much, Chairman. I think this work is really, really important, especially my particular portfolio of looking at economic development and skills and the link to housing and the need for people to feel that they have hope, if you like, in the workplace and to feel that they've got that support. I think doing this in partnership is the only way we're going to get there, and joining up not just resources and ideas and being a bit more creative in how we do things differently, but ultimately it's got to be an outcome-driven engagement so that we can actually start to have proper measures of the impacts we're having. So I'm very much really supportive of this paper and hope that we can, get this signed up and get started. Thank you.
Great. Thank you, Gloria. I take it that being a subgroup, it reports back to. And how often, Sharon, do you think that was going to take place?
So my hope would be that Gloria and I will be in a position to bring a progress report back to the board in January, which will be able to talk about, we'll be able to share the terms of reference for the programme board membership. We'll hopefully have some feedback by then. Hopefully we will have had one meeting, so we should be in a position to be able to bring a report back in January. Yes, thank you, Chair.
Right. So I take it that, shall I move to the recommendation then? So the recommendation that members approve the development of a work and health programme for Thurrock, and it be led by the Director of Public Health and I can't remember your job title again, Gloria.
Chief Officer for Housing, Economic Development, Skills and Regeneration. Apologies, it's
That's a long title. That needs an abbreviation, doesn't it? Right. The establishment of a work and health programme board as a subgroup of the Health and Wellbeing Board to oversee the delivery of the programme. Is that recommendation approved? Yes? Thank you. Thank you for that, Sharon. I think that's a really positive step. Right, so move on to agenda item 6, the Department of Health and Social Care letter, 10-year health plan. We've got 10 minutes for this, so I'll ask if Rob would like to present this.
Thank you, Chair. So this paper's come to Health Wellbeing Board to really make sure that all the members and anybody that's watching on the webcast is aware that on the 21st of October, the Secretary of State for Health and Social Care, Wes Streeting, wrote to all chief execs in the NHS and local authorities, writing, and he's written basically announcing a significant consultation for the NHS. The letter's titled Change the NHS, Help Build a Health Service Fit for the Future. The timeline indicated, there's no specific timeline indicated for this consultation, which I think is a positive thing, because what I think the intention is to play this over a number of months and make sure the consultation is meaningful. So there are a number of bits within the letter I just wanted to raise awareness to. There will be a toolkit being provided to local authorities and, I guess, NHS organisations at some point later this month, which will support the approach they wish to undertake in undertaking public consultation. There's 3 key drivers within the letter. Those drivers fundamentally are to try and shift more care into the community. So they're looking to see explicitly move resources from the acute sector into community services within the NHS. They're looking at the better use of technology and the future use of the whole digital agenda. I think that could be both back office, but it could also be front, the things which actually mean something to patients and service users and communities. So, for example, wearable devices as an example. And they're wanting to focus, a real focus on preventing ill health in the first place, which I think is where it brings in everybody into this whole agenda. Now then, I've had a number of discussions with a number of individuals within the council, with NHS colleagues and with our voluntary community sector partners. And what I'm proposing is that we'll bring an outlined options proposal to TICA, which is a Thurrock Integrated Care Alliance, in December, just proposing how we're going to approach this consultation to make sure that we engage with everybody. So I don't really want to go into too much detail here at the moment, other than I have spoken with Mark and Kim at CVS and Healthwatch about possibly exploring whether this could be a process that's led from within communities. And obviously, new to Thurrock, but being very impressed with the 4 integrated locality team approach we have. They seem to provide a potential vehicle for us to drive this consultation through over the coming months. So it's really to raise awareness of the fact this consultation is being asked for. I think it's an opportunity where we can both profile what I'm seeing in Thurrock as the very strong foundation. I think you should give yourselves credit as a community here for the work you've done in this space over recent years, but also use that platform as a real opportunity to launch even more going forward. So this to me is a potential opportunity, but it's not just for health and social care to have this view. It is for our VCS partners, it's for the other directors in the council, and it's for our communities more generally, whether they're engaged in primary care services, community services, or whether they're just sort of, they're sort of well and not engaging on a regular basis. They should still have a view, and we need to find a way to make sure they get engaged in giving those opinions as we go forward. So it's really to raise awareness of the process and to commit to bringing this back to the Health and Wellbeing Board when we've got an approach and when we know how we're going to plan this consultation, so that we can feedback here what the consultation is telling us, what the public want to see is prioritised as we move forward. Thank you, Chair.
Thank you. Rita?
Thank you, Chair, and thank you, Rob. This is a welcome opportunity. We have an excellent strategy behind us that we're partway through in terms of delivering. Real shift of focus towards prevention. And you're absolutely right, Rob, in terms of our integrated locality teams and the work we're doing around integrated care hubs, etc. This is a real shift. And actually, health partners are looking to solutions. So we have some really good opportunities here of what things have worked, what we could do more of going forward. and really drive that prevention agenda and sort of allow for the community voices to be heard in terms of what is their priority.
Thank you, Rita. Sharon?
Thank you, Chair. I agree with the comments that have already been made. I just wonder if there is an opportunity to link the work on the consultation on the change in the NHS and the 10-year plan to the new health and wellbeing strategy. So our current health and wellbeing strategy takes us until 2026. Next year, we will be wanting to go out and engage with citizens, communities, etc., on the priorities for the new health and wellbeing strategy. It seems to me that would be an ideal opportunity to link those two things together. We know that people can get tired of being consulted too often, and I think that if we are going to be bringing back a proposal to consult with people, partners and citizens on this piece of work, we can combine it with the refresh of the health and wellbeing strategy as well, Chair.
Okay. Any other comments? No? I think our strategy in Thurrock has been absolutely brilliant, and prevention is far better and cheaper. And I actually hope other local authorities and our health partners in other areas learn from us, actually. So, can I move to the recommendation, please? It's recommended that members note the content of the letter and actions that will be taken in response to the consultation. So we've noted that, yes. Thank you. Right, if that's okay, I'll move on to item 7, which is a Health Watch report on hospital discharge. We have 25 minutes for this. Now, I know that the letter was commissioned by Margaret Allen. And would you like to say a little bit about why you commissioned it before I ask Kim to present?
Thank you, Chair. Yes, the report, it's an insight report that was commissioned from Health Watch Thurrock in June of 2023. And we really valued their independent approach to helping us define what our transfer of care hub should look like and the challenges that it needed to focus on around hospital discharge and also a degree of admission avoidance. But it was really commissioned so that we had a full picture. You know, we have data sets, we have professional insights, we have all of those things. What we really needed was also the voice of people who are being discharged from hospital and what their experience is actually like, good and not so good. And I think that Health Watch have done a really, really helpful report, and it has in fact been informing how our transfer of care hub is operating, to the point that it has been externally evaluated, and we are told that in Mid and South Essex, the Thurrock transfer of care hub is the closest to that Claire Fuller designed in the Fuller Stocktake report from 3 years ago. Thank you.
Thank you, Margaret. Okay. So the report can be found on page 21 of today's papers. So if I could just ask Kim to do a presentation. I think there's 10 minutes for the presentation, Kim, but there's a little bit of leeway there. And I think there's about 15 minutes for discussion.
Okay, thank you very much, Chair. First of all, I think just to make sure that everybody realises the reason for there being a Health Watch and what Health Watch's role is and why we were asked to do this. As Margaret has said, we are very much independent, and we find that staff appreciate that when they speak to us, people that are delivering services, because they can speak in confidence and we are able to feed back their concerns as well. Health Watch England, who is the main body, oversees all the work we do at a local level. So they can actually raise concerns to CQC level for there to be national pieces of work done. And some of the work that we do, it has been commissioned by Health Watch England on behalf of the CQC to give a whole picture of all of the work we do. So apart from the commissioned work we do lots of work that is informed by people's experiences. So that can be maternity services, it can be primary care, it can be dental. We work with children as well, so it can be young people's views on their mental health services. And over the years, we've done many, many pieces of work independently and commissioned. And a lot of that work has informed the way things are commissioned moving forward. So we were quite pleased to do this, as we'd actually picked up lots and lots of issues, complaints, concerns from various sources, including people themselves, their families, people that provide care for people once they return home after a discharge. So it was very, very widespread. It's still very much, although we've finished this piece of work for the talk, it is still a very live piece of work because it hasn't stopped as yet. So we felt that we gave a really balanced view. We spoke to lots of people, lots of stories of, or lived experience, they're not stories, they're people's actual experiences of being discharged that went really well or didn't. We fully understand that the pressures that people are under within the system is immense, and that we truthfully believe that nobody intends any harm to be done to people. It's just sometimes these people fall through the gaps and are found at home in quite a sorry state. We spoke to staff, many, many staff within the hospital, within the system, within the community, and they raised their concerns. But that again was a very balanced view, because some of them felt that the system was good, lots of them didn't, and they had really serious concerns about the safety and welfare of some people. So the fact that the TOC has taken this on, are going to work with it, is great. Health Watch, because of our powers, are able to give recommendations or make recommendations. But we felt on this one, we went through it and through it and through it, the main concerns were around communication. That ran right the way through the report. It was communication with families, communication with the person themselves, communication with the care services that should have come out and looked after them, and between staff as well. So on this one, we actually just done a final overview, which shows that throughout the report, we have looked at both professional and patients' lived experience of the current discharge pathway. Whilst every respondent shared their own personal experiences, concerns and successes, it is evident throughout this report that all of the concerns and successes came down to communication. The theme of communication is present in every single person's lived experience, whether this be positive or negative. So firstly, the issues around communication systems between the 3 Mid and South Essex hospitals, when they merged into one trust, and we've seen multiple times throughout this report examples of patients from Thurrock who have attended Broomfield or Southend not being discharged back correctly into Thurrock. The merge between the 3 hospitals should not affect patients in a negative way, but enhance their care experience in a seamless manner. Following on from this, the current pressure discharge, lack of capacity and increases in local demand can all be felt by the patient. This can be seen in many of the case studies throughout. Whilst the current environment clearly creates barriers and causes of concern for staff, it also impacts the patient and creates a fragmented experience for everyone involved. The high pressure environment patients and professionals are currently in can be seen to create a level of anxiety and concern around the accuracy of the care provided, which could equate to a lack of trust. It's clear there is more support needed for both professionals and patients to operate effectively in the given environment. In response to this, Healthwatch Thurrock would like to have an agreement for us to facilitate a workshop between the most relevant representatives and work through some case studies to identify where the breakdown in communication was. This is to aid in a positive way for both professionals and patients. And since this report has been to many different places, we are being asked by the Trust, by various people in the community, when this piece of work can happen. So I'm really hoping that after today, that is something that we can now work together to facilitate, to try and identify where those pinch points are, and maybe put in more support for the professionals to be able to, for that to reflect in the care of the people being discharged in Thurrock. Thank you.
Thank you, Margaret. Are there any questions? Gloria.
Just not, well, more an observation really. I'm just reading through the report myself and some of the kind of comments. It's not just about, from my observation, the communication, it's the quality of the communication. And one of the things that I'm always picking up in any service that we deliver is about what's going to happen when people want to know time frames, etc. And I'm just picking up some of those things on specific information that people need to be able to make informed decisions is really at the heart of all of this. So that's what really needs to be. So when we say communication, we need to be very specific on what it is that we're communicating to whom, why, who, what, why, where, and when, in effect. Thank you.
Thank you. I think this is a great report. I'm so grateful for it. It really does open our eyes up to some of the challenges we have. I have a few questions, if you don't mind, though. I thought that Thurrock had its discharge team based at the hospital. Is that still the case?
There are some elements of it still there, as in our social workers. There was a bigger team there and lots went through them directly. But there was a big consultation and some of those staff have now been pulled out and are working in the community-led support teams. There is still a small cohort of staff for Thurrock in there. They do visit the wards and they do make calls to make sure that care is in place, but they don't pick everybody up, but they never did when they were a full team either. It was if somebody needed social care input, and sometimes not all of them do. Sometimes people already have a package of care in place, and if that is assessed as still being suitable, they wouldn't necessarily pick them up. But what happens then is if the wards can't get hold of, or if it's a sudden discharge, sometimes those care packages are not put in place straight away as soon as the person comes home. And that, again, is just communication. So they are still there in a smaller form.
Margaret?
Thank you. So a couple of things, actually. First of all, we do still have the hospital social workers in the hospital, but as Kim alluded to, there have been some changes around the hospital social work team. And the second thing is that during this winter period, there has been a discharge cell established. It started on Monday of this week. It will carry out its functions until the end of March next year, and that is there to pick up on those really challenging, complex discharges that sometimes the staff that are working in the transfer of care hubs are really working with a lot of different cases, and then it is possible that you get a really poor discharge because something is really complex and it just bypasses TOC. So the discharge cell will actually be focusing on those very complicated, very, very challenging discharges, which should then complement what the TOCs are doing right across Mid and South Essex, and certainly in Thurrock. We have one of the best established TOCs across the whole of the ICB patch.
Okay, does that work across all three hospitals or just the one?
The TOC works across all three hospitals. We very occasionally do get a Thurrock resident who ends up in Broomfield, up at Chelmsford. We certainly do have some Thurrock residents that end up in Southend Hospital, particularly around oncology services. The majority of Thurrock residents do go into Basildon, but we even have some that go into the neighbouring London hospitals as well.
So, Kim, you mentioned that the hospital trust taking on board your recommendations, and I know you've made recommendations, but what's the next plan? What's the next part of this?
So the Foundation Trust are very keen to work with us to look at the issues that were highlighted. The cell that Margaret spoke of, we've been involved in that conversation, and CVS also run the By Your Side Home from Hospital project, which is where a lot of people are getting picked up from, and they have invited Ruby, who manages that service, to be part of that cell, so that when she finds or that anything happens or doesn't go right, she's got someone to refer straight back to. So she will be heavily involved in that. And more so now with the remaining hospital team that are there, social work team, to work closer with them on the wards at point of discharge. So we've increased the capacity of that service. So the next thing is for us to be given the okay to start looking at putting together a workshop. Very aware we're now hitting winter pressures. Everybody's busy. But I think that the hospital and community service is still very, very keen to just have a look at it before we hit too deep into winter, if there's anything that can be ironed out and put in place as a safety net, apart from obviously the element that Margaret spoke of. I think that's right, Rita. Yeah.
Okay, Rita.
Thank you. And again, welcome the report. What's also really beneficial in this report is actually it talks about how the staff feel through this process as well. And actually what we also need to acknowledge, yes, we've gone through a transformation, so we have a smaller hub of social workers in the hospital as part of our overall strategy around prevention. It is important that we have social workers out in the 4 community-led support teams. However, we do have increasing demands on the services right across, both in terms of the number of discharges coming through the hospital team and also the pressures back out in the community. So that going back to our previous conversation around prevention, that will be the solution here. Because actually what we're trying to do is minimise the amount of time people actually even spend in hospital, and we try and keep them as at home where possible as well. So I welcome this. I think the timing is perfect because actually as we now step into winter, what this report has allowed us to do is further have those conversations with our acute partners and what the teams in Thurrock are also doing. So our own transformation team in local authority is also working with Kim and the hospital team and the management within the hospital team to look at a further human learning experiment to actually understand the journey of some of our residents and where things are not quite going right. And it goes back to your point around quality of communication as well.
I was quite disturbed by some of the stories, though. I think there was a story about a lady who was sent home. She had staples that seemed to be wanting to be suggested that your report that she took them out herself because there was no district nursing involvement. Is that right, or I got wrong?
She didn't take them out herself. She was discharged. She was quite elderly. She'd had quite major surgery in the oncology team. And she did come up on the list of discharges. We received the list every day. And a welfare or wellbeing call was put into her. And she said that she was okay, but she wasn't sure what to do with all the stuff that she was given. So when one of the staff went round there to speak to her, she had come out with all of the things that she needed, the dressings and the staple remover and all sorts of things. And she truly believed that she was to do all of that herself. She was very concerned that she didn't think she'd be able to bend over and do that herself. So luckily, because we'd gone in within 48 hours of her being discharged, that we never reached that point. Her 10 days was never reached. So a phone call was put into the community team and they went round and had a long conversation with her and supported her moving forward. So she was ready to, she was preparing herself to, but she didn't.
So in terms of discharge, district nurses then, how are they informed that they've got a patient in their area that actually needs some help?
So I think that a referral form or a referral is made to them. I think probably Rita's more clued up, well, obviously it's your team, so how that happens. And what happened was this was a South End discharge. We had a few of them, we had a run of them that was the same sort of thing, nothing had been, they had no referrals. And when we went back, when it was looked into by the hospital, there seemed to be a misunderstanding between some staff that they couldn't do a referral form for anybody that was out of area, which was anybody living outside of Southend. And they felt some of that could possibly be agency nursing, but it was one of the things we raised immediately as a concern. It was looked into, and touch wood, things have been better with those referral forms coming out at discharge.
I would reiterate the point Kim made, though. So there is a process in terms of from a ward, in terms of actually referral forms being made out back into the community. And it goes back to actually the pace at which things are being done on the wards as well. It's that element of housekeeping, is everything being done, and actually the quality of the referrals coming out to community teams and people acknowledging that we have urgent community response teams, but we also have planned community nursing teams as well, who wouldn't necessarily respond on that day as well. So it's an acknowledgement about and understanding the roles of the different teams as well.
I have to say that the urgent response team in Thurrock and Thurrock First truly are amazing, because it doesn't matter what time of day that somebody is found or there's an issue with somebody, that they don't pick that up. And we have stayed with patients until somebody has arrived, and they have been there very, very quickly. So I think that is a really good support network for people that slip through the net, for them to be picked up and not left. So doing this report, anything that we found, we dealt with immediately. We didn't just wait for the report. I don't want anybody thinking these people have left at home.
That's good to hear. Has the hospital changed its discharge policy?
Not that I know of. I think it's something that they're looking at, isn't it, Margaret? But I don't think they've changed their policy. The pathways, I think TOCs are identifying issues, and that's where I think the changes will be made moving forward.
Nationally, discharge policy for hospitals, for acute hospitals, was changed some time ago. And whereas we used to use the term medically fit for discharge, it is now medically optimised and has been for quite some time. But that was a national policy. I'm not aware that Mid and South Essex Foundation Trust has changed its policy since then.
Okay, thank you. And going forward, how are we going to monitor this in the future?
As I said, we still are picking patients up or issues up. We still have staff contacting us. We are going to, I spoke to our advisory group, they want this to be left running as a live piece of work, so that we can start looking at whether, if things slow down, whether they're changing and people are, that some of those gaps have been identified. But I think that the hospitals are so keen now to work with us that I think that there's more understanding, and that I feel we are now in a far better position to raise any concerns if we start feeling that it's all falling off the cliff again. We've always worked really closely with providers and commissioners, and we very rarely, over those 15 years, have we used our powers, and that's not something we want to do. But we need to have really good working relationships, and that when we pick the phone up, I think Rita always says, if I pick the phone up to her, she knows it's going to be bad, whereas normally I'll email or we'll chase somebody around, whatever. So we try not to do that, but obviously if we find something that's really dangerous, then we will make those calls straight away. but I think it's just monitoring it for a little while. We're hitting winter, always gets bad at winter. We know that. We know there's an awful lot of pressures, but it's whether people are safe. And if they're safe, then that's fine. But by running the By Your Side project, which is now sort of 7 days a week, we pick those people up really quickly. They are called within a minimum of 24 hours, or maximum of 24 hours from discharge. So we're managing to pick them up very, very quickly. And we get the entire Thurrock list every morning.
Thank you, Kim. It's good to know. Any other questions?
So there's another point, Chair, in terms of the reason that Thurrock is seen as having, as Margaret has referenced, a more mature transfer of care hub approach is because we have Thurrock First, we have By Your Side, we have local area coordinators, and they are all linked into those frontline teams across health and care. And it was on those merits that we were considered to have the most mature of sort of transfer of care hubs when the hubs first came out as a concept, and at the time of Margaret and colleagues commissioning the work for HealthWatch to follow through. Obviously, what would be helpful is that this was presented at TICA, so Thurrock Integrated Care Alliance, and obviously at that board we have representation from MSEFT as well. So as partners we are held to account through TICA as well, and that's our highest governing arrangements within Thurrock as well. So I would expect this to come back regularly through that board as well.
Okay, I'll be really interested myself, maybe even come back in about 6 months' time, maybe March, and look at this again. Thank you. So, if there's no other questions, if I can move to the recommendation, and the recommendation is that members note the content of the report, comment upon key themes and challenges that may be identified in the report. So, are they noted? Thank you. Thank you again for that report. I found it really, really helpful. And thank you, Margaret, for commissioning the report. Right, if I can move on to item 8, please, which is the Health Wellbeing Strategy Overview and Performance Update, which Sharon will be presenting. We've got 55 minutes for this item. The documents can be found on page 57. So I think we've got 15 minutes for a presentation and then 35 minutes for questions. So over to you, Sharon.
Thank you, Chair. So, in your report papers, you have a detailed report on the progress that's being made against the key elements in the health and wellbeing strategy. Quite a lot of detail in there. So, thinking about time, if I can ask you please to refer to your presentation, which I think printed copies were circulated. As the Chair mentioned at the start of the meeting, the IT system this evening has a couple of gremlins in it, and it won't allow for verbal presentation, but if you can refer to the printed copy. First of all then, the presentation really starts by setting the scene in relation to the health and wellbeing strategy. So the Health and Social Care Act 2012 and the amended Health and Social Care Act date, which I've temporarily forgotten, places a statutory duty for all local authorities to establish a health and wellbeing board for their area. So that's all unitary or upper local authorities to establish a health and wellbeing board and to develop a joint health and wellbeing strategy. And NHS integrated care systems are required to reflect the local authority joint health and wellbeing strategy in their area for all of the local authorities in their jurisdiction. And certainly the Mid and South Essex the Integrated Care Board and the Integrated Care Partnership does indeed reflect the Thurrock Health and Wellbeing Strategy. So because a number of members of the board are new, it's useful just to reflect on how the health and wellbeing strategy was developed. And a 12-week consultation exercise took place during 2021, which involved a range of methods of consultation, including going to various communities, groups, etc. But the CVS and Health Watch also played a key role in supporting the consultation exercise by undertaking surveys and setting up workshops and through various methods to engage with residents. Obviously, that engagement was very successful. There were over 750 individual comments received through the questionnaire, and there were in excess of 300 residents and professionals involved in the planning, with over 1,300 comments on the proposals. So the strategy was developed through extensive consultation and engagement. The strategy then is really intended to act as a whole system plan to improve health and wellbeing outcomes for the people of Thurrock. And though that whole system plan is organised under a number of work streams or domains. So staying healthier for longer, building strong and cohesive communities, person-led health and care, opportunity for all, housing and the environment, and community safety. And each of those domains, if you look at the detailed report in the report pack, has got a number of high-level actions, sets out a number of actions that the board wanted to see through the strategy, and then an update. And so that detailed paper just takes you through some of the key progress that's being made. So just pulling out a couple of key bits under Domain 1, staying healthier for longer. It's important to recognise that the health and wellbeing strategy is an overarching strategy for Thurrock. It's a statutory strategy, as I said at the start, but it does align with a number of other strategies. So the Thurrock Integrated Care Alliance, Further Case for Change, the Brighter Future strategy that focuses on children and young people, and improving outcomes for children, young people and families throughout Thurrock. So first, one of the areas that we wanted to focus on was smoking and obesity. Two areas particularly highlighted there. So today, some of you that have had time to review the media reports today, the tobacco strategy and vapes bill was presented to Parliament today, so it will now be working its way through the governance processes at Westminster. I haven't had a chance yet to read that in any detail. I've been in meetings all day, but what that does do is introduce some further restrictions on smoking and vaping in public places, such as outside hospitals, outside schools, play areas, for example, which will be further consulted on. So once that tobacco and vapes bill has been approved, we will need to review our tobacco control strategy and action plan to take on board that. To highlight in terms of obesity, People Overview and Scrutiny Committee have established a childhood obesity task and finish group. They're investigating issues around childhood obesity in Thurrock. That report will be presented to People Overview and Scrutiny Committee in January, and any recommendations that Scrutiny wish to make can be reflected in the new healthy weight strategy that we're developing to replace the old whole system obesity strategy. There's a great deal of work happening around substance misuse. One really good example is the Complex Housing Intervention Team, the CHIP project, as we call it. That's been established as a pilot to address housing issues, really for those residents that have quite complex behavioural challenges and often a dual diagnosis of mental health issues and addiction, as well as homelessness. The early indications from that pilot are that it is making a difference to those residents and savings across the system. And it may be, Chair, that the Health and Wellbeing Board would like to receive a further report on that once the evaluation has been completed. We've already heard earlier in the board meeting about the excellent partnership working that is happening across health and care in Thurrock. There is further work that is going on now, led by the ICB, but involving other partners, including primary care and the council, looking at alternative ways to deliver the benefits of the integrated medical and wellbeing centre model across the borough. And we look forward to receiving further information on that at a future board meeting. Looking then at Domain 2, the building stronger and cohesive communities. This again is very much aligned with the Thurrock Community Safety Partnership and the work that goes on through that partnership, which is highlighted under Domain 5, I think, in the report. But also to Stronger Together Thurrock. So highlighted here, we have the new resource Frontline. I always think of that as being a flea treatment for dogs, but I've been assured that isn't the case here, that we have a really successful programme called Frontline. It doesn't just act as a database and repository for information that's happening across Thurrock, but it also provides a system that allows for referrals into Frontline, whether that be from a health and care professional or whether it be from a citizen. The system allows those referrals to be tracked to ensure that connections are being made. It seems as though that system is being effective, but we want more people to use it. So bit of a plug here for more people to use that system. And then there are lots of examples being led by the communities engagement team in the council and other partners as well around testing new approaches to really capture the voice of communities. There's also then a calendar of various events that happens. I'm quite new to Thurrock, but there will be colleagues on the board who will be very familiar with a range of annual events that happen in Thurrock that are again really exciting and innovative ways of being able to engage with communities, such as the Interfaith Week, for example. Moving on then to Domain 3, person-led health and care. Here we've picked out the work to celebrate around the integrated locality teams. There are colleagues here who know much more of the detail of the integrated locality teams than I do, but again, what we're able to see are real benefits from having that partnership working at the level of place through the integrated locality teams and the engagement of the primary care networks and GPs, and again highlighted here that joint working that's taking place between the ICB and the council to really looking at joining up our estate strategy to be able to make best use and deliver improved outcomes for citizens in terms of how we can better use our joint estate. We're also then through the integrated learning teams, the ILTs, testing different ways of working. So looking at the opportunity of developing generic roles, looking at how we can break down professional barriers between different professional groups with a clear focus on delivering improved health and well-being outcomes for residents, and then really starting to look at a different place-based model of commissioning that allows us to look at what we call micro commissioning or place-based commissioning, again through the integrated learning teams, that allows the system to be able to be much more focused on the need of particular communities at place. Moving on then to domain 4, this links to the earlier agenda item, Chair, on work and health. There are fantastic opportunities in Thurrock being generated through the Thames Freeport. There's a lot of investment coming into Thurrock. There's a real opportunity to be able to tap into some of that investment and work with businesses differently to be able to deliver our aspirations, not just around work and health, but as highlighted here, very much linked to the Brighter Future strategy and the aspirations that we have for our children and young people in Thurrock. And some examples listed there around apprenticeships for children with special and educational needs, work that's being done around our children leaving care, and then pre-employment programs for our young people as well. And then a range of interventions described there around a job and skills club, supporting young people to be able to, around CV preparation, interview skills, numeracy, etc. So a whole range of opportunities being explored there. Touching on workplace health again, that's listed again here, that links to the discussion that we had earlier, and very much focused on developing better links with our businesses and really looking at partnerships as the bullet point there at the bottom of that page. Moving on to housing and the environment then, domain 5. There is a priority around reducing homelessness and increasing the supply of affordable housing in Thurrock. Just a couple of examples there listed about the pre-eviction panel, changing the way that we work with council tenants that may be on the cusp of being evicted, and how we can have a multi-agency approach, which links to the pilot project, the CHIP project I mentioned earlier, that is particularly focused on working with people with mental health and other issues, and then the homelessness prevention and rough sleeping strategy. There's also work going on to address the quality of housing in Thurrock through the housing asset management strategy and the housing strategy. We're very aware of the impacts of hazards such as cold, damp and mould on the health and well-being of residents. So there are further examples of the work that's being undertaken in the detailed report in your pack. Work looking at particular client groups, so the Housing Domestic Abuse Policy, very much linked to the Domestic Abuse Act of 2021, that the Act changes our approach as a system to how we support victims of domestic abuse and providing safe accommodation for them, and also looking at safe and stable housing for survivors of domestic abuse. The Domestic Abuse Act 2021 for the first time highlighted children and young people who may be witnesses of domestic abuse as requiring support in a much stronger way than they were previously before the Act. So as you can see listed here, part of the work around survivors of domestic abuse is very much focused on children and young people and ensuring that there is therapy and support for those children and young people affected. Looking at regeneration then, issues such as air pollution, community resilience, the Council has adopted Health in All Policies place shaping guidance, which is being used to inform the local plan. Air quality is a particular issue for us in Thurrock. It is a concern, I know, for many residents. We are doing air quality monitoring in Thurrock, but as has been explained here, and I don't know, Michael, you may be able to say a little bit more about this. I understand some of that work has been delayed because we need to have the transport modelling done, and that transport modelling will then inform the development of the air quality strategy and action plan. But I'm aware that Thurrock is also part of a Greater Essex approach, and they're looking at developing an air quality management plan, I think, for Greater Essex that Thurrock is part of, but Michael may be able to say more about that. So then the final domain, community safety. I think what you can see through this strategy is that a number of elements are cross-cutting, that they don't just sit in one domain, they are cross-cutting with other domains. And so part of the approach, which hopefully you've seen come through in the progress report, tries to illustrate how we're trying to work as a system in pulling some of these together. So under this domain, our Essex Police colleague may want to say something here about the Essex Serious Youth Violence Strategy, the work that is happening through the Community Safety Partnership around gang violence, and also looking at how we can develop a much better approach to avoiding school exclusions, diversionary tactics, etc. This obviously links across to the Brighter Future strategy as well, and Sheila, we've had a number of discussions about this area at the Brighter Futures Board, so that just illustrates my point about cross-partner working. Also looking at reducing reoffending, there's a lot of work happening there, and some really innovative work, I think, that's being supported through the Police, Fire and Crime Commissioner that is also starting to demonstrate some really positive impacts. We have a Combating Drugs Partnership for Thurrock. Thurrock hosts that partnership currently across Southend, Essex and Thurrock, and lots of work happening there. And then the violence against women and girls strategy, work around sexual behaviours, harmful sexual behaviours, and then examples of some of the work that's being done to protect residents from being the victims of crime. So that's just a whistle-stop tour, really, of some of the highlights of the work that's going on. So finally then, in terms of recommendations, Chair, so the board is asked to know and comment on some of the progress that's being made, and hopefully members of the board will want to comment and perhaps highlight some areas that may not have been captured in this progress report that they want to bring to the board's attention. The strategy is now 2 years old, 2.5 years old. We're already starting to think about the next strategy. I would suggest that a lot of the work that's being done is now business as usual. It's embedded and the work is happening. So rather than the board necessarily having a detailed progress report against everything in future, would the board prefer to have a discussion and focus on the key things? So what are the absolutely key burning issues that you think as a board we need to focus on over the remaining life of the strategy, so that we can really focus on what those priorities are and focus on driving the improvement in outcomes we want to see for perhaps a smaller number of priorities than the whole range of priorities we have in the strategy at the moment. So that's really for discussion. And then, as we've already alluded to, Chair, a report will come forward about the process for refreshing the health and wellbeing strategy, work that we need to do next year to prepare for having a new strategy for 2026. Thank you, Chair.
Thank you, Sharon. Any questions? Margaret?
Thank you, yes. I've just got one. I'm just curious, if the drug and alcohol funding might be reduced, is there a plan B?
Sorry, can you repeat that, Margaret?
Yeah, I'm just wondering about the funding, the grant funding that is given out to different organisations around this sort of area. And I'm just curious to know whether there might be a reduction in grant funding. I'm not suggesting there is, it's a question. But if there might be a reduction in grant funding, is there a plan B to actually support those?
Okay, so just to explain to colleagues, quite a bit of our substance misuse work, and I don't mean just drug treatment, I mean all the work around tackling substance misuse, is funded through two public health funding streams at the moment. Partly through the public health grant, the local authority public health grant, and partly through what we call a Section 31 grant, which is a separate grant that comes down from government, which is aimed at reducing crime from substance misuse. It's focused on looking at drugs rehabilitation, etc. The Section 31 grant, the Supplementary Drug Treatment Grant, as we call it, is only confirmed until the 31st of March next year. There's been no announcement from government as to what they intend to do about funding that substance misuse activity from the 1st of April onwards. Clearly, that is a concern. It's not just a concern for Thurrock, it's a concern for every local authority and director of public health across the country. There's a lot of lobbying going on of government to try and illustrate the question that Margaret's just raised about the impact. If this funding were to be lost, what would the impact be? So we've started doing that work in Thurrock now. So we haven't got a plan B yet, but we're doing the work now to really get a granular understanding of what we think the impact would be if that funding were lost, and then we can look at mitigations and coming up with a plan B. So work in progress, Chair, and if the board would be interested, then obviously we can bring a report back here that will illustrate what the likely impact might be and the mitigations that we're putting in place.
Thank you, Sharon. Any other questions?
Not a question, just an observation on some of the strategies that's been mentioned here. The homelessness strategy, as people will be aware, the council, all councils have a statutory duty to have a compliant strategy before it expires. And we're in the process of reviewing the homelessness strategy at the moment. So that's going through an iteration and so on. So as and when I can bring the relevant officer to kind of come and talk through the updated version that is going through the process. The other thing that we will be looking at, hasn't started yet, is a revision of the housing strategy, just to double check it's fit for purpose so that we're actually delivering, because as a whole, as you've gone through and touched through some of the things here in terms of need, there's an ample demand for need. Demand and supplies is a challenge, not just for Thurrock, but everywhere, but particularly here. So some of these strategies are being revised. So again, we'll make sure we feed that in. Last but not least, I also am aware that we're looking at a revised cultural strategy. So cultural strategy, in a sense, will be a strategy that we are working with our cultural sector and creative industries and so on, key sectors, so that the council is an enabler and facilitator for the delivery of that strategy. So those are the three things I wanted to touch on in my area.
Thank you. I'm really pleased that we're reviewing the housing strategy. Rob.
Yeah, thank you. So can I just say, number one, thank you to Sharon, because that's quite a detailed presentation. There's a lot of information in there that's really useful to go through. Can I secondly say thanks to Gloria for bringing to life a little bit about some of the work that's going on and how it links together. And I'm just wondering whether to make just a brief observation, more for possibly anybody that is watching this. So if you look at Domain 1, Staying Healthy for Longer, it's about providing some context into this. So just to try and bring it to life for people, and I won't quote figures because I'll get them wrong, but if you were to look from east to west and go from Tilbury through Grays through to Purfleet-on-Thames, if you looked at the life expectancy across that band and compared to the north of the borough, you'll find a significant differential. So there's a health inequality there that this is about trying to address, because we want to try and reduce that health inequality by trying to raise the life expectancy profile. The other thing that links to that is, one of the things we focus on is trying to improve healthy life expectancy. So you'll be aware, generally, it's a good thing, people live longer these days. Unfortunately, the healthy life expectancy, so the point at which people have a significant number of long-term conditions, which may, linking to the earlier presentation around work and health, may limit their ability to engage in the workplace, may affect their quality of life, is actually staying stable or reducing in many places. So the gap is increasing. So when we talk about staying healthy for longer, rather than seeing it as just a headline, I think it's really useful for people to kind of understand the context we're operating in and what we're really trying to achieve as far as an outcome is concerned. And I just think in future, you know, when we revisit this, it'd be useful to just kind of look through the different domains and probably bring to life a little bit of kind of what this means within the context of Thurrock and how it impacts on people's lives. But I think the presentation's got a huge amount of content in there, which gives us a building block to take forward. Final comment would be on the refresh, linking to the NHS consultation, the suggestion earlier. I'd possibly just suggest to the board members that we bring this back rather than early 25, maybe spring, early summer 25, because at that point we'll be able to link it to anything that's coming out from the public consultation around the NHS and link it to kind of how we could play that into the refresh of the strategy. Thank you.
And we'll have a new council. Okay, I mean, in terms of, there's a lot here. Yeah, but in terms of priorities, where do you think our priorities should sit? I mean, I think housing needs to be one of them because I think we are actually really in a housing crisis right now. Do any of the board have a view? Margaret?
I think homelessness, housing, getting people into work, are really they're no-brainers, aren't they? They are some of the key things, particularly the air quality for people in Thurrock and particularly around Tilbury and Purfleet. It's some of the worst in the country. So I think they're obvious things, and I think reducing health inequalities overall, and that's where primary care, community health services, acute services, the ICB, we can all play a part as far as that goes. And actually that links into the ICB's priorities as well.
That's good to hear.
Thanks, Chair. Just on the air quality, it was delayed due to some third-party data that's been coming in. That has been extended for a year. However, we have got a hard deadline of October next year for all of that data and the strategy to come through. The air standards report, which is yearly, that has already been sent to DEFRA and that has been approved with only some minor amendments being made by our officers at the moment. That, once completed, will go through its normal governance process and will be published online.
That seems a long way away, October. Our colleagues are ahead of us, aren't they, when we're not really taking part in the air quality strategies across Essex at the moment. We don't have a strategy because of this one area. So is there any likelihood that can be brought forward?
I should say it's an ultimate deadline. That's not what we're aiming for. So I should be able to update the board in due course once we actually finalise some of that data coming from the third party. But like I say, that's a limit to the report. That's not a target date.
Okay, thank you. Rita?
Thank you, Chair. Again, I would second what Margaret said, but I'd really like to make sure that we stay focused on the key domains here because they are interlinked as laid out earlier on by Sharon. The prevention is key and mental health. And I suppose, we'd be seconded there by Sheila in terms of all age as well there, but certainly from an adult's perspective, we really need to concentrate on mental health as well.
Okay. Can I ask, so we're kind of setting some work here, yeah, for the feedback that you as a board are giving. So identifying those kind of priority areas. So who's going to be the kind of sponsor domain for this?
So if I can make an observation, being relatively new to Thurrock, not the newest, but relatively new, what we've got in the current strategy is a very broad strategy. It's got lots of really good things in it, but it's really difficult when you look at it to really pick out what is the difference we want to make, what is the measurable difference we want to make to the people living and working in Thurrock. So if we talk about reducing health inequalities, absolutely, and I would say that's an overarching goal for the whole of the strategy, is to focus on reducing health inequalities. How are we going to know that we've done that? Where is our baseline data? Where's our stretch targets? How are we going to know whether we've made a difference? The same if we look at community safety, if we think about youth violence or whatever it might be. What we've got is a narrative report that gives us very rich information about the work that's happening, but it doesn't allow us to know whether that work is actually delivering an impact. So I would like to propose that if this is the list of priorities we want to focus on, so housing, homelessness, getting people into work, air quality, I would say indoor air quality, not just transport related and industry related air quality issues, a focus on prevention, mental health. If those are the areas we want to focus on, then I think what we need are some board members who are willing to take a bit of a champion role in bringing the relevant people together and to say, okay, so what in housing? What in 18 months' time does this board, being accountable to the residents of York, what does this board want to see that has changed from today to 18 months' time? Similarly with homelessness, what is the change that this board wants to see from now to 18 months' time? The same with work, the same with mental health. Otherwise, we have a strategy that is a brilliant strategy. I really enjoyed reading it when I was applying for the job here in Thurrock. Read it with great interest and thought it was an amazing strategy, really well written, all of the key things in it. But what is missing is the so what question. Okay, we're doing all of this brilliant work which we've described, and we can bring another report to the board next year that is updated with all the more brilliant work that we're doing. But how do we demonstrate that it's made a difference? So for me, that is what I would like this board to commit to, so that we can do the work outside this meeting with key sponsors from the board, so that we can bring a report back, hopefully to the January meeting, which actually sets out what are the real measurable outcomes we want to see for residents, so that when we are reporting back the strategy 2006, we're signing off the strategy, right, this is done, we're on to the next, we know the difference that we've made. And I don't think we could answer that question at the moment. I'm happy to be challenged on that, but kind of that's my view currently. Thank you, Chair.
Gloria.
I couldn't agree more. I'm very much an outcome-focused and driven professional, and I think that certainly on the housing side, I can help champion that because we're doing that anyway. And my ambition is to ensure that whilst it's sat in one directorate, actually it needs to be owned corporately. So we will do that as a given anyway. So I will ensure that that is brought back here and champion that.
Thank you, that's great.
Obviously, I would put myself forward for the champion of the community safety domain. I'm going to be the chair of the community safety partnership, so it's a good position to hold and have direct control over both aspects.
Thank you. What else have we got? Air quality. Who would feedback on that or take that as a domain?
Because air quality is within Domain 5, if Gloria is taking housing, I completely agree with Gloria. It's not really just a directorate issue, it is a corporate issue. So I'll work with Gloria in terms of the air quality, because there very much is two crossovers around public protection as well as housing and regeneration, etc. So between me and Gloria, we'll be able to ensure that the air quality aspect of Domain 5 is covered.
Okay, thank you. Right, so do we not already have a subgroup we've agreed today? on getting people into work. You don't know what we're talking about here. In getting people into work. Sorry about that.
Yeah, so the new subgroup that the board approved earlier in the meeting, which, so the work programme that Gloria and I will be leading on, so that would be, I would suggest that that group, that board, the Work and Health Board, takes the lead on getting people into work. Obviously, we don't know who the chair is going to be yet, but I think it would be that group that would take the leadership for that. Reducing health inequalities clearly sits with me. So I will certainly be very happy to bring a report back that really gives the board a really good understanding of what the health inequalities are in Thurrock at the moment, the causes of those inequalities, and what the evidence suggests are the positive actions that we can put in place to reduce those. I certainly am happy to take the lead on that.
Thank you. Is that something Margaret and Rita will be involved with as well?
Yeah. Involve a range.
Okay, mental health. Is that something you could take the lead on, Rita?
Yeah, absolutely. Again, it will be part of our integrated working, but absolutely happy to take the lead.
Or prevention. It's hard to think of a lead on that one because we're all doing it in different places, aren't we?
Can I suggest, Chair, in other local authorities I've worked in and health and wellbeing boards I've been a member of, the board, rather than trying to duplicate work that is going on elsewhere, has actually received reports from those groups. So the Better Care Together Thurrock Executive and the Further Case for Change strategy, as Rita alluded to earlier, is very much predicated on that prevention approach. Currently, the board doesn't receive any minutes from that group. There's no report that feeds back to the Health and Wellbeing Board on the work of that group. So I would suggest that one of the ways we might tackle this is to bring a highlight report to the board from the Better Care Together Thurrock meetings, so that the board can be cited on the work and have an opportunity to ask any questions. I think doing it that way, rather than trying to set up another work stream focused on prevention, would seem to be a prudent approach.
Yeah, this may lose some people on the webcast, but certainly for the board members, I think that makes a lot of sense. So, again, as I'm only a few weeks in, but some of the conversation I'm having, just so people are aware, there is a Better Care Together board which kind of operationalises the delivery of what we're doing on the ground, how we work together, how we're delivering outcomes to the population. What sits above that is that, as has been mentioned in this meeting, is the Thurrock Integrated Care Alliance, TICA. I've only experienced one meeting, and it may be inappropriate, but I have spoken to a couple of people. That, in the meetings I had, that very much seemed to duplicate the agenda. Those two meetings duplicated the agenda. And I think we're reflecting, and we'd like to think of TICA as being more strategic. So that's the strategic meeting. Now then, I believe that TICA is set up to, from a governance point of view, to report to the Health Wellbeing Board. So I think there's actually a route here whereby we will look at just refreshing the terms reference for three boards: the TICA, the Better Care Together Board, and what's called the ICE, the Integrated Commissioning Executive, and actually look at how those three, how the ICE and the Better Care Together Board report up into TICA, and TICA would be the mechanism by which we could report into Health and Wellbeing Board. And so that really just provides the framework to support what Sharon is suggesting. If that's okay with people, we'll explore that over the next 2 months and bring a proposal for the governance arrangements to early into 2025.
So you putting your name in the hat for that, Rob? Are you putting your name in the hat for that, Rob, to do the overall?
I'll put my name in the hat to bring a paper in January, in early 25, which explains the governance oversight, yeah, but...
Okay. Rita?
In that same spirit and the approach around the governance, it's the same challenge around mental health, because we are reviewing our Thurrock Mental Health Transformation Board. And then obviously we've got the South End Essex and Thurrock overriding strategy board as well. So that it is under review at the moment. So it should be the same principles.
Great, thank you. So we're basically asking for people to come back in January with suggestions for the goals or areas we're working on.
January doesn't feel like very long away, does it, with Christmas and New Year in between? What I think, well, some of this work is going to be easier than others. Some of it is going to be more straightforward than others. So I think the named leads, if they can bring back a report, might just be a highlight report to the January meeting, which may just describe what's happening now and some proposals for further papers that might come to the Health and Wellbeing Board, so that we can start to map out a forward plan for the board and future agenda items. I think that even if we're only able to do that for some of these areas at the January meeting, that will allow the board to be in a really strong position at the start of 2025 to kind of map out some of this work for the 18 months ahead. So the January meeting might be just a bit of a reset of what the board has been functioning like up to now, and a bit of a reset, as Rob's already alluded to, in terms of reports that we might get from some of the partnership groups that are already meeting. You know, another might be the Brighter Futures Board. We haven't had any focus on children and young people today, so it might be that just as we might get a highlight report from Chico, we might get a highlight report from the Brighter Futures Board, for example, so that the board is cited on issues that affect children and young people as well. So, but we can have some discussions outside this meeting, Chair, about how we'd like to take some of this forward.
Okay, thank you. Are there any other comments? No? Okay. So I think I just need to tidy things up a little bit. So we note the comments upon progress has been made by delivering the strategy outcomes provided in Appendix B. We noted? Yes, we've noted. Okay. Comments and agree upon how to address priorities have engaged since the strategy has been launched in July 22. So we've done that. So we reviewed and provided feedback on options for the continued monitoring and reporting of the strategy. Well, we've decided to bring it back here in January with some reports. Yes. And we've identified the domains for each of the priorities each of the priorities we've agreed to today. Right. Well, I think that's it, isn't it? So we're reporting in early January 25. Yes. Is there any other business? No? Okay, then I will call the meeting to a close. Thank you very much.